Now I call upon Dr. Subashini to deliver a talk on surgical management, the role of glaucoma surgeon.
Hello again. So far we had seen the last previous speakers have spoken on the causes, the mechanisms for these secondary glaucomas, as well as then how to evaluate systematically, and then the non-surgical management. So I would be talking about the surgical management. So which are the glaucomas which require surgical intervention? So as far as I can see, so it's only a small proportion of the glaucomas. Mainly it's the neovascular glaucoma, then some of the glaucomas following vitreoretinal surgery, and I'll also touch upon the choroidal detachment, which occurs as a complication following any glaucoma surgery for these conditions. So moving on to neovascular glaucoma. So majority, especially in the open angle stage, it's managed medically. So the management actually not only consists of only reduction in the IOPs, so by medications and by surgery, we also have to inhibit the neovascular drive. So, and that is done by panretinal photocoagulation and anti-VEGFs. So the indications for the surgical treatment of neovascular glaucoma are when there is valuable visual acuity and insufficient pharmacological control of the IOP, and when there's a closed antechamber angle due to synechiae. And literature has shown that more than 50% of the eyes with neovascular glaucoma require surgical IOP control. The options we have in hand are, one is the trabeculectomy with MMC, then the glaucoma drainage device, and the CPC. So talking about trabeculectomy with MMC, so the success rate is much less compared to a TRAB in other glaucomas which is done. So it ranges between 62 to 80% in some studies at 1 year, and it further decreases over the years. So it's very important that preoperative intravitreal bevacizumab injection be given before a trabeculectomy, but because it has shown to improve the surgical outcomes and reduce the postoperative risk of hyphema. And there's a study which has shown that primary TRAB combined with intravitreal injection of bevacizumab and subconjunctival MMC, it resulted in decreased IOP compared to just use of subconjunctival MMC without intravitreal injection. So it's become standard practice that intravitreal injections are given 1 or 2 weeks before planning the trabeculectomy surgery. So this is a quick surgical video of how a trabeculectomy is done. So in TRAB in neovascular glaucoma, it's better to avoid the superior rectus brittle suture, better to take a corneal suture, but because it can induce some hematoma and cause more inflammation and failure. So I had injected mitomycin 20 microgram, and then now raised a phonics-based conjunctival flap. The cautery is done. So the rest of the steps are just like for a regular TRAB. A triangular groove is made, and the flap is raised. A partial thickness little flap is raised. So after entering the chamber, then with a Kelly punch, you can punch out 2 or 3 punches of the corneal scleral tissue. After the PI, the chamber is formed and checked for the flow through the scleral flap, and then we suture the flap. The conjunctiva is sutured snugly. And you can depress near the scleral flap and check whether the bleb is forming. So this is the post-op picture, and you can see there is no hyphema, and the bleb is well formed, and pressure also was under control. So moving on to glaucoma drainage devices, this is preferred if the trabeculectomy fails or when there's a high risk of failure. So many people straight away go for GDDs in neovascular glaucoma because there's a high incidence of conjunctival scarring and inflammation in these cases. So now the question is whether to choose whether a valved implant or a non-valved implant. And be it a valved or a non-valved, here again, just like for a trab, it's good to use preoperative adjuvant bevacizumab or any other anti-VEGFs, and this actually improves the surgical outcome. Though there are some studies which show contradictory reports that it doesn't have a role. Choosing between Ahmed and Burwell, there's a study, and this has shown that Burwell has an upper edge, and the pressure control is much better with Burwell than with Ahmed. The failure rate is also less. This is a video of glaucoma drainage device. Here I have used the RD implant. You can see the conjunctiva being scarred because of the pars plana vitrectomy that was done in this case. First, the muscle, the superior rectus and the lateral rectus are identified, as we usually plan to place the GDD in the supratemporal quadrant. After the priming, the ripcord suture is placed. This is a 3-0 supramed suture. Then the vicryl tie, 1 or 2 sutures are placed with 6-0 vicryl. Then the plate is placed such that the wings of the plate are under the muscles. Nothing different from the usual kind of surgeries. Okay. Moving on to the glaucomas following vitreoretinal surgery. And I mean, here it depends on what type of surgery. So if it's a scleral buckle, so what can be done? We saw the mechanisms which was elaborately told by Dr. Amit. So when there's a scleral buckle, so in the early stages, you can just think of just loosening the encirclage band. That itself would help to control the pressures. So the other, if it is an old case of scleral buckle, then some say you can even insert the tube into the capsule of the pre-existing encircling band. So the capsule which is formed by the encircling band, into that you can insert just the tube. The other way is like placing a GDD, and then you can trim the plate because of the lack of space, because of the band occupying that area. So you can trim the plate. Or in most cases, it's much easy. So you can just place a plate over the band and do as a regular surgery. In case of pars plana vitrectomy, glaucoma following pars plana vitrectomy, we can consider placing a pars plana tube if the cornea is compromised or if it's a post-PKI, or you can even use an antechamber tube if the chamber is well formed and there are no peripheral anterior-synechiae. For glaucomas, because of silicone oil removal itself is not enough. That's what studies have shown. So you might have to combine with the glaucoma surgery. So trabs have been tried, but with poor success rate, and so has been with express shunt and GAT. So there are some studies which have been done on these glaucomas, but the efficiency is much less. So the best option would be to go for a glaucoma drainage tube with an inferior, placing the tube inferiorly, because if you place the tube superiorly, the silicone oil can just enter the tube and then escape through the tube to the subconjunctival area over the bleb that is formed over the plate, and this can induce a lot of inflammation and fibrosis, and the GDD also can fail. With respect to glaucomas following use of these intravitreal gases, here again you can place a GDD and either in the pars plana scleral fistula, or you can place an antechamber tube. So, talking about choroidal detachment following the surgeries for these secondary glaucomas, a serous choroidal detachment can occur following a bleb leak or overfiltration. Following a trabeculectomy, and here you can see the chamber is very shallow because of overfiltration, and you can see the kissing choroidals on fundus examination. And it's not necessary that for serous choroidal detachment that you have to immediately drain the choroidal fluid. So we can temporarily manage conservatively. So you can use atropine eye ointment and help to push the iris lens diaphragm backwards and allow for the fluid to absorb. So you can even give oral steroids to help in faster absorption of the fluid. The risk factors for a serous choroidal detachment are hypertension, older age, prior vitrectomy, nanophthalmus, and elevated episcleral venous pressure as seen in Sturge-Weber's and other conditions. So management conservative, as I said, topical steroids, atropine, and oral steroids. Intervention can be just a mild intervention by just forming the antechamber. That itself would be enough. But choroidal drainage would be considered in these conditions. So when there's a flat anterior chamber with lens corneal touch in the center, kissing choroidals, and the hypotony is there for a long duration. So this is how a choroidal drainage is done by the glaucoma surgeon. A radial incision is made around 2.5 to 3 mm from the limbus. You have to magnify the area, then hold the lips of the incision using 0.12, that's the limbs forceps, and then gently deepen the incision till you reach the suprachoroidal space, then pass a cyclodialysis spatula into the suprachoroidal space and to break any loculets, pockets of fluid which are there. You can see that straw-colored fluid coming out. So you need not, you don't have to suture the scleral inside sclera. So just the conjunctival suturing would do. The other way is by here again a radial incision is made. A better method is by placing a anterior chamber maintainer. So this will help prevent collapse of the anterior chamber. So that's what. So this is in short, in a nutshell, how you manage surgically these glaucomas.